we'll give people another minute and then we'll make a start. I just wanted to let everyone know that this session is being recorded. If you wouldn't want your face to appear on the recording, please turn off your cameras. Lovely, I'll make a start. If I can please ask you to answer for us the following questions. Do you know a medical physicist? Lovely, I can see lots of answers coming in. Okay, let's have a look at the results then for this. Oh, okay. So most of you don't know a medical physicist yet, but you are due to meet how many? 7 of us today. So we hope we can change that. Then are you interested in a career in medical physics? Let's see. Oh, wow. That's very positive. And a question about the workforce. There are a lot more medical physicists who identify as male than medical physicists that identify as female. Is that true or false? Let's have a look. Oh, true. Well, Kat will talk to us about that in a little while. So we'll hear more about gender statistics in medical physics later on today. And where do we work? Where do medical physicists work? In a lab, in an office, with patients, from home, or all of the above? All of the above, that sounds quite right. And do all of us work with ionizing radiation? No, very good. And finally, oh, not finally, sorry, 2 more. Do you know how to become a medical physicist? Okay, so let's hope we can explain a little bit more later today with a session about the training scheme. And finally, can you have a research career if you are a medical physicist? Yes, excellent. So thank you very much for your questions, for your answers to our questions. We will repeat these questions at the end of the session and see what your conclusions from today's session are. But for now, I will pass the baton on to my colleague Angela, who will introduce today's workshop.
Great, thanks, Vera. You need to stop sharing, Sophia. I stopped you sharing, sorry. Right, we will get on.
Thank you.
Hopefully I'm sharing my screen and I am spotlighted, I hope. Spotlight for everyone. There we go. So after a little bit of Zoom faffing, which always has to take place, Welcome everyone to this session on medical physics and careers in medical physics. My name's Angela Darrick and I'm the lead for MRI Physics here in Southampton, working at University Hospital Southampton within the medical physics department. So a very quick intro to what medical physics is. If you don't know what it is, I hope some of you have been exposed to it during your undergrad degrees. So the main areas are radiotherapy physics, radiation protection, and linked to that, radiological physics and non-ionizing radiation protection. And my area is MRI physics, and then two kind of slightly smaller areas but still have physicists employed in them are ultrasound physics and specialist physiological measurement that kind of catches lots of other stuff. But they're the main areas. You will hear all about them during this session, so I won't go into details now. But what is medical physics at UHS? So we're a reasonably typical department. We're a very multidisciplinary department. As well as physicists, we've got computer scientists and engineers and radiographers and technologists, and I think some nursing staff in there and support staff, admin staff as well. So a fairly diverse bunch of about 70 people working for the NHS in Southampton. And we are organised into three groups within our department. So we have radiotherapy physics, and Jen will be talking about that group in a little while. And it's probably the biggest, it is the biggest group in our department. Then we've got radiation protection, which also includes non-ionizing radiation protection. And I can't remember, Kat, I think, is talking about radiation protection later on. And then we've got imaging physics, which includes a few of us. So we've got nuclear medicine physics, and Sophia, who you just saw, will be talking about that area, MRI physics, which is my area. And then we've got neurological physics, which is looking at brain physiological measurements, and a scientific computing team. They're led by blokes, so they're not here, but you might hear a bit about them. And they are, and the scientific computing team supports the rest of our group in imaging physics. So what do we all do? So there's three main themes, I'd say, and that's one, providing, developing and supporting clinical services. So some of us in the department actually provide that clinical service to patients, but the rest of us support other clinical services, providing clinical services to the patients, directly to the patients. So we support those services in lots of different ways. And one of those is ensuring safety. So we all deal with slightly dodgy things. So whether that's radiation, UV, lasers, or big magnets, in my case, all have their own safety issues. So we do a lot of safety management and the understanding of the science behind our techniques to manage that safety. And then lastly, we also do some research and development within our department, and we enable it as well as lead it. And I'll talk a bit about that. And I think Sophia probably will as well in our talks. But who do we work with? Now, we work with a large range of people, and I think that's one of the really nice things about medical physics, is that we get to interact with a huge range of people across the hospital and elsewhere on our day-to-day business. Big departments that we work with are people like radiology and oncology, who are very involved in our service and vice versa. But then we also interact with people who work in theatres to do with laser safety, for example, and then other clinical departments like neurosciences and cardiology. But we also work with the University of Southampton, who are organising this in terms of research and teaching, and we have other hospitals. We don't just support the people in our hospital, we also provide services across our region. So we're pretty busy. And the last bit of this introduction really was my take on why women in medical physics. I thought, well, we have to talk about why we want women to come into medical physics. And I thought, well, the reason is diversity, and that sounds really obvious, but the reason that we want people to be diverse in medical physics is because I think we're quite a problem-solving type of profession. We are chucked lots of problems on a daily basis, and we need a range of people and voices and talents and opinions and perspectives to solve all those problems in the most efficient and effective and the best way possible. And that's what the NHS needs as well. And we can only do that if we've got the widest range of people available to us to employ. And we're half the population, so we have to include women. But we also may well take a different approach to solving those problems to the other half of the population. And we need women to be represented at every level. We need our profession to develop and evolve and move forward. And that's why we need people like you to help us do that. And this is slightly controversial, but I certainly remember when I went to conferences early in my career, there are lots of grey men in grey suits. That I remember going to one conference and it was just a sea of grey, and they're very nice people, but we need to get away from that. We need to represent the people that we're trying to serve, i.e. our patients, and we need diversity to do that. And those skills and those opinions and that expertise only comes from you. No one else can do it. So that's why I think we need women in medical physics. So thanks, that was the intro. I hope that's given you a taster. We have Q&A at the end, but if you can put questions in the Zoom chat, we'll try and answer those as well, but we'll do that at the end. So I'm going to pass on, if I can get the tech right, I'm going to stop sharing and pass on to Rachel, who's going to talk about training routes, I think. And I also need to remove my spotlight.
Thank you, Angela. That was really good. I'm just going to share my presentation. Okay, so hopefully that's a slideshow, and I don't know, am I spotlighted? No, because my camera's off. Ooh. Okay. Okay, so I think I'll just start. So my name's Rachel Barlow. I'm a principal clinical scientist here. I actually work in the radiotherapy department, which is the same department as Jen, and she'll talk to you a little bit later about radiotherapy. I'm going to talk a little bit broader about sort of workforce and sort of careers and how you can get into medical physics and the different areas, different sort of types of roles you might like to train to do. This is just a little bit background about myself. So I'm the deputy head of department. So I have two kind of main streams to my role. One of them is operational management. So these include things like workforce planning and recruitment, capacity and demand modelling, strategic planning, training and development, and staff management. So some of those are kind of obvious what they are. The capacity and demand modelling, so particularly in radiotherapy, we have up to sort of 30% variation in the amount of work coming through in terms of treatments of patients. And so we have to sort of manage those peaks and troughs of workload coming into department, make sure we've got the appropriate staff available and the appropriate skills mix in order to deliver the work that's required. Strategic planning is kind of looking forward to new developments that are coming through. So we're often driven by the manufacturers that make the equipment we use. And if we see that they are developing a new piece of kit that we want to then adopt in the future, we have to make sure we write the business cases to get the staff on board and the money available for training staff and buying the equipment when it actually becomes available to purchase. The other side of my role, which is perhaps the more interesting part for me, is the scientific support. So I'm a medical physics expert. So in medical physics, you have to have what we call medical physics experts in all the areas. And the biggest part of that is to really give advice. So I give advice to doctors, to radiographers, to other scientists, to technicians. Sometimes it's doing sort of calculations when we've made a mistake or an error, and we have to quantify what that mistake might be. Other times it's advising clinicians on the best way to treat something if we've got an unusual case and it's not clear how we'd go about that. I'm involved in lots of commissioning projects, so I tend to sort of drive and manage the staff doing the actual day-to-day work on the commissioning projects, and then I'll sort of review and sign off the reports at the end. I'm involved in procurement of new equipment, so I write tender documents for kind of £2 million machines, and then review what's on the market and make decisions as to which we should be purchasing. Service developments I've talked a little bit about before. I'm also the quality manager for radiotherapy physics, so I make sure that all our documentation is up to date and reviewed, and we have external auditors coming in annually, which I have to engage with and make sure we're successful in those audit programs. Just a little bit background about my career path. I did a fairly sort of standard career path at the time. So I did a BA Physics at Oxford University, and then I was successful on this. At the time, it was the training scheme called the Grade A training scheme. I did this in London, and that included a part-time master's in radiation physics with medical applications, which I did at Queen Mary Westfield. I've actually, for my first job, was a nuclear medicine physicist, and I did this for about 3 years. Before moving over to do radiotherapy physics. That was mainly driven by kind of workforce and job opportunities. And then I completed my higher training, which is a 4-year training program. I then took a post of head of quality assurance and dosimetry down here at Southampton, which I did for probably about 3 or 4 years. And then I applied to become the deputy head of department, which is the role that I'm in now. So the medical physics workforce then is made up, as Angela said, lots of different groups of staff. So we've got clinical scientists, we've got clinical technologists, we've got mechanical and electrical engineers, we've got software engineers, radiographers, healthcare assistants, and admin assistants. And we all work together. Some of the roles overlap, but we all sort of, work together as a big team, as well as linking in with teams outside of our department, so the clinicians and other staff, to make sure that we deliver the best service possible to our patients. So all our work, either indirectly or directly, is driven by delivering the best service we can to our patients. And this is just showing the kind of numbers of staff we have at Southampton in each of those areas. So you can see the biggest staff group is the clinical scientists. And then the next biggest would be the sort of technologists and radiographers. Just talking a little bit about the careers then. So in, I think it was 2008, the Modernising Scientific Careers came about. And this was a UK-wide education and training strategy for the whole of the healthcare science workforce. And this identified 4 levels of the workforce and the training programs relevant to each. So it starts off sort of with an associate assistant workforce role. Then there's a sort of more of a technician role, which was actually delivered by a practitioner training program. This has since been replaced by the level 6 apprentice, which is an undergraduate level training program. The next level up is the scientist training program, which then delivers clinical scientists. So that's a postgrad level training scheme. And then there's a 4th level, which is called the higher specialist scientific training. So this is like a taught PhD. We do have someone in our department actually on this training scheme, but it's a much smaller training scheme, obviously, than the STP program. And the idea behind this was to really try and generate what they called consultant clinical scientists. And in some of the areas which are sort of more patient facing, so sort of the genomics and the life sciences, actually they were using these people in these positions to replace doctors. So it was a kind of good way of getting skills mix and a bit of a cost saving, to be honest, in some of those other areas. In medical physics, that sort of role isn't possible, but there are still some people who are on that training scheme. So just to pick out 2 of the roles that I mentioned, which are more relevant to sort of physics graduates, we've got the technologist training route. So there's kind of 2 of those. There's the apprentice that I mentioned before, and we'll share all these links afterwards with you. And there's also the IPEM technologist training scheme. So that's the Institute of Physics and Engineering in Medicine, which is a professional body that we're all members of. And they have a sort of in-house training scheme where you can sort of learn on the job. The entry would be sort of physics A levels or physics degree. And then afterwards you apply to IPEM for your sort of registration document that you can then apply for registration with them. And then the other main area available to physics graduates is the clinical scientist training program. So there is going to be a talk on the STP later, so I won't go into too many details. So the main one is the STP, but there are other ways of becoming a clinical scientist in medical physics. You've got the IPEM Route 2. So this is kind of, again, a bit more of a on-the-job training. where you sort of have a bit of a portfolio, and then you can use IPEM as a way of getting your equivalents graded and accepted. And then there's also the STP equivalence route. This is where you have to evidence that you've completed work very similar to the STP training scheme. And once you have your equivalent certificate, you can then apply to the Healthcare Professionals Council, which is the professional body that we all have to be registered in order to be registered clinical scientists. And then you can be awarded during that route. So there's kind of 3 routes really for to become a clinical scientist. And that's the end of my slides. So I will pass you on to Kat. Thank you very much. Stop share.
Thank you, Rachel.
Thank you.
Okay, can everyone see my presentation? Hopefully. Yeah. Yep, perfect. So my name's Kat. I'm a clinical scientist. I'll be talking to you again a little bit later about actually what I do in medical physics. I'm actually part of the radiation protection team. But just quickly, I was just going to share a few slides about gender and physics careers. This is the Women in Physics conference. So I was just going to look at the divide between males and females in physics careers in the UK. So first of all, I was looking at the statistics for people that enter into physics degrees. So I've chosen the University of Southampton. First of all, I'll just really quickly talk about definitions here. So I'm going to be talking about males and females. I don't know necessarily how people's genders were established for some of these statistics. So it's possible that gender fluid or non-binary people may not have been represented, but throughout this afternoon, we're all going to be referring to male and female people. It's not to say that we don't, welcome people with other gender identities. So we've got females, the female undergraduate fraction as the y-axis on this graph. And we can see that basically at the University of Southampton, and we're looking at about 1 in 4 people who enter onto the degrees in physics and astronomy. These are statistics going up to 2017, 2018. There is a slight rise in new entrants and female new entrants, which is great to see. But still, 2019, 2020 is the latest numbers that I have. And the first year undergraduates, 21% were female, and 23% of all undergraduates. So that's the incoming first year undergraduates, 21% were female. And in the academic year 2019, 2020, 23% total of all undergraduates were female. Interestingly, also, as of October 2017, the university staff working in physics and astronomy, about 21% female. So secondly, so that's University of Southampton, but what about the NHS? Actually, we find that the NHS is quite a female-dominated place to work for, with 75% of all NHS staff being female at the moment. Well, this data is pretty recent. However, females are in the minority in senior roles in the NHS. And doctors, the majority still are male. However, there has been quite a sharp rise in the number of females becoming doctors. So in 2019, 41% of doctors were female, and in 2018, 45% of doctors were female. So we're reaching, it looks like we're on the way to getting a pretty much 50-50 divide male to female doctors. Then what about medical physics? So medical physics is physics generally. You can be a medical physicist and a physicist and not work for the NHS, but I think the vast majority do work for the NHS. And interestingly, we have a rough ratio across the UK of about 50% male and 50% female medical physicists. it's actually, when I asked the Institute of Physics and Engineering in Medicine, which is the society that Rachel was referring to earlier, their membership is fairly representative of medical physicists and engineers, and about 55% were male and 45% were female. And in our department here, of the 70 people that we have working for us, if I look at just the people that are scientists and technologists, the people in the sort of the physicsy careers, it's almost exactly 50%. So it's 53% male and 47% female. So I'm not sure exactly for the reasons why, although we tend to see quite male-dominated university undergraduate courses in physics, then when that translates to medical physics, we actually find things evening out. I do know that the NHS is a fantastic employer for diversity and inclusion, so perhaps that's a factor, but it's pretty positive statistics for medical physics anyway. So that was a really quick introduction to gender statistics in medical physics, and I'm now going to pass you over back to Angela Darragh to talk a bit more about her work in MRI physics. Thank you.
Just thought I'd say that I'm running out of music. Thank you, Kat. We'll just do a bit of faffing around again. Let me just share my screen. Lovely. And I think I'm spotlighted. Right, let's go again. So thanks, Kat. That was a really, really good treatment of the issue. And thanks for explaining the whole, I just went, women are 50% of the population. It's not that clear cut really, but yeah, so now I'm going to talk a little bit about my area of physics, which is MRI physics, and my journey, which has mainly been in Southampton. It's not very exciting, I'm afraid. So I'm the lead for MRI physics, and I'll start with saying, how did I get here? But I thought I should explain what here is really. Here is lead for MRI physics, and in UHS, it's a small team of 3 physicists, and I lead that group, and I have done for a long time. But I'm also our MR safety expert. So Rachel talked about medical physics experts, so each area has their equivalent. I am that for MRI safety, but I also have other roles. I'm our regional imaging research champion, and I also chair a national committee as part of the NIHR, which is our NHS research kind of entity, which is the Imaging Research Delivery Group. So I have a kind of range of things going on, unfortunately. And a bit like Rachel, you know, our jobs are fairly kind of diverse, really. There are lots of aspects to what we do. I work full time a lot, and I've been here a long time. I've been here 22 years, and I started, now I'm giving away my age here, but started as a newly qualified physicist, pretty much straight after uni at the age of 24. And I've not had any career breaks along the way. And in terms of my kind of academic journey, that started at Imperial, and I did a BSc in physics at Imperial. I then went to Aberdeen just for a year to do a master's because I wasn't quite sure what I wanted to do, but I wanted to do something in medical physics. I then decided I wanted to do the training scheme, and it was called the Grade A training scheme in my day too, probably at the same time as Rachel. And I was in South London. I was at King's College London, where I got a place on the clinical scientist training scheme, and I also did another master's, and don't ask me why, at King's. And then for my sins, whilst I've been here in Southampton, I've done a part-time PhD as well, based in the Faculty of Medicine, looking at brain MRI and changes in blood pressure and the effect that has on our brain. So that's kind of my academic career, and all of that time since I finished my training at King's, I have been in Southampton and developed myself and my career, I suppose, here really. And I'll explain a bit more about what my area of work is going forward. So MRI, what is it? I hope some of you know what MRI is, but in case you don't, it is a cross-sectional imaging modality, which means we can see slices of the body in any plane, and it uses this is very simple physics, magnetic fields and radio frequency fields to produce those images of the body. And the fact that it's a non-ionizing imaging technique is particularly useful, and I'll explain why later, but it means we don't have to worry about dose so much or at all. And the good thing about MRI is that it provides a huge range of information across lots of different types of tissues in the body and different types of images. So we can do lots of different types of imaging in one examination. So you can look at the structure of the body, we can look at how the components of the body fit together, the different organs. We can also look at blood flow and blood vessels through the body. We can look at things like diffusion, which looks at water molecules and how they diffuse through the body. That gives us a different type of information. Blood perfusion again, and things like iron concentration, and also more functional MRI. And in this case, functional MRI is looking at brain activity. So we can produce some lovely images in one sitting, really. So we can get all these different types of images of the brain from, not from one MRI scan, but one MRI session, which would have lots of different scans within it. And they all have different contrasts, and that's due to the way we can manipulate our physics, really, of MRI to get those different types of images. And we can produce images of things like the white matter tracts in the brain, so where the wiring in the brain is and how that all connects up. We can produce images of the heart. We can do lots of things, and most of the time that's used for diagnosis, so working out what's wrong with a person. But we can also use those images to monitor disease and plan treatments and interventions to treat that disease, and also understand the mechanisms of diseases. So why a particular disease affects the body in a certain way. And eventually we hope we can predict outcomes. So how a disease progresses in a person based on imaging at one time point, see how it all goes forward. And then it can also read it can't read your mind, but one of the things that we do is functional MRI, as I mentioned, and that's looking at how the brain responds to activity. In this case is a patient where we looked at language activation in the brain, and you can see those areas of the brain have lit up, as the papers like to call it. It's due to an increase in blood flow in those areas that we can detect, but we can see things like that. So in Southampton, we cover a huge range of areas. So flicking through very quickly, we've got things like brain injury and disease, fetal, that's a fetal brain up there in the tummy, fetal and neonatal imaging, brain imaging applied to psychology, cardiac imaging. We've got a dedicated cardiac MRI scanner, which is pretty busy. We do a lot of cardiac work. Liver disease. We're starting to look at lungs, which are tricky using MR because air doesn't really give us very much contrast, but we're managing it. And then things like bioengineering and musculoskeletal scanning for both clinical and research work, looking at joints and muscles. The big area of interest obviously is oncology and using MRI to diagnose, but then also monitor and plan treatments. And one of those treatments that we do is interventional MRI. So using something like, in this case, a cryogen gas or a cryogen liquid injected into a prostate, but done under image guidance. So whilst a patient is in the scanner, and we can ablate the prostate using that cryogen. And that's quite a new area of work. So how does MR physics fit into all of that? Well, as part of my job, we do lots of different things, but Rachel mentioned this in relation to radiotherapy kit, but we do the same for MRI kit. We specify our equipment and procure that equipment and then plan the installation of that equipment with a lot of other people. But once that kit is in place, we also test it initially to check it's working, but keep testing it as time goes on to make sure it's maintaining its performance. But then we also support advanced MRI techniques. So some of the things I was just talking about, and that's both for clinical work and for research work, and especially somewhere like Southampton, which is a large regional centre. And then we, really importantly, provide a lot of safety advice. So I'm the MR safety expert for the Trust, and quite often the last point of call for any MRI safety issues. An MR scanner is a big magnet that has a lot of safety issues to do with it, and we have to have a safety framework to manage that. But we also have to manage what we put into the patient. We're putting radio frequency energy, not ionizing radiation energy, but radio frequency energy into a patient, manage how we do that so that we don't fry our patients. We don't fry our patients, don't worry. And then lastly, we've got the bit that I think is interesting, the research stuff that we do, and we do different aspects of that. So we act quite a lot of the time as a link between academics and clinicians, and being that conduit between the two because of our technical knowledge. We implement and we develop research techniques in a clinical setting, so getting those research techniques working on patients for clinical research questions. We advise on things like image processing, and I think Sophia will talk a lot more about this in nuclear medicine, but to extract numbers from our images, which are useful things to do in research. And I've put at the bottom, generally run around doing MRI research, quite a lot of operational and managerial work relating to MRI research here in Southampton. And then I've put, why am I still here? I said, how did I get here? And why am I still here? I'm not sure sometimes, but what is on the horizon? And MR is a fairly fast moving field actually, and probably quite a fast developing field compared to lots of areas of medical physics. There's a lot of new research, a lot of new applications. And so we're always trying to implement those to help our patients and best benefit those patients. But it also means we're getting more patients, which means we're getting busier, which is good for the patients, not so good for us. But we need to do things like evidence-based imaging. So we need to provide the hard evidence that the imaging that we're using is beneficial and appropriate for our patients. And then we need to use the advanced techniques. And some of these that are coming up are things like fast imaging. MR takes a little while, but we're getting faster at it. Hybrid and multimodality MR things, so PET MR and MR Linacs. And then higher field strength magnets, which produce images with better signal to noise ratio and higher resolution. And they're still pretty, 7 Tesla magnets are still research really. We're still using 1.5 and 3 for our clinical work. And then things like AI and machine learning and quantification, all those whizzy bits of image processing that you can do, but that's so that we can diagnose disease much better and much more precisely for a patient, so that we know how to treat an individual patient most appropriately. And then lastly, I've put treatment planning. It's not just about diagnosing a patient, it's using those images to appropriately treat and then manage that patient going forward. And things like intraoperative MRI and interventional MRI are big areas that, especially in Southampton, that we're doing more of. And they have their own challenges around safety. And then lastly, I thought I'd just say, who do we need? And I'm sure other people will talk about this as well, but we need lots of different types of people. I talked about diversity, but we need people who can think creatively and think outside of the box to apply physics and MRI physics to real world clinical problems and needs. But we also need people who can think pragmatically about those solutions and implement them in quite challenging environments, and whether that's challenging from a process point of view or from a technical point of view or a people point of view. We need to do that, but we need to do that by communicating our science well and communicating it to lots of different people, and that can be really interesting but challenging as well. But we need to do that to engage the people that we work with, to help the patients at the end of the day, to innovate, and then to influence people to use the things that we want them to use. And the last bit I put is that we want people to be experts in their area of work. And as physicists, you're often quite a small group of people, so you have to be the expert in your area of work and have the confidence to lead and say that you can be the expert in that area of work. And we need people to be able to do that, but we need a diverse range of people to be able to do that. So we need you, basically. And I think that's where I'm ending. Yes, there we go. Thank you. So I will now pass on. Let me stop sharing. And I've forgotten who's next.
It's me.
It's Sophia. Yay. So Sophia's going to talk about nuclear medicine. There we go.
Let's see, so hopefully you can now see a full screen. Perfect. So hi again. I am going to talk to you a little bit about nuclear medicine physics. I work at Southampton as a principal clinical scientist in nuclear medicine. My journey before getting here started in Greece, where I did the BSc in physics while I was working part-time in retail. and then did my MSc in medical physics, both at the University of Patras. And I was teaching part-time at the same time. Now, any work to do with retail, hospitality, or anything that gets you to talk to people is actually good preparation for a career at the NHS, any career at the NHS, because we do need to talk to a lot of people most of the time. Then I moved over to London, where I did my PhD in medical imaging. And at the time, I was also teaching programming. This is a bit of an unusual career. You don't usually need MSc or PhD prior to joining the NHS for clinical training. And as a matter of fact, there might be better ways to do it. The STP training offers the opportunity to do a part-time MSc that is paid for by the training scheme. So I wouldn't really advise you to follow my route, but it is one possibility if you're thinking of returning back after a PhD. I joined the training scheme in London North Consortium. That was before the STP was designed. And I did placements in radiotherapy, nuclear medicine, and diagnostic radiology across different London hospitals. And then at 27, I got my first permanent job as a clinical scientist at University College London Hospital. I stayed there for a few years until I moved to University Hospital Southampton in 2015. And I've been working here since 2015 as a principal clinical scientist. I work in nuclear medicine, and this is a discipline where we use radiopharmaceuticals. This is medicinal products labeled with radioactive tracers. We inject those to people to look at their body function to try and diagnose and treat disease. As a clinical scientist and a medical physics expert for nuclear medicine and for positron emission tomography, I lead the development of imaging services. Our imaging has applications in oncology, in cardiology, and in neurology. I also develop and deliver radionuclide therapies to our patients to treat primarily cancer or other conditions that cause pain. And I provide physics advice for clinical and research procedures. A smallish part of my job, but quite an interesting one, is teaching and supervision, both teaching hospital staff and also teaching at the university. More recently, I started a new part-time role in research and development, where I'm working with the NHS Topol Digital Fellowship and a SAPE Award. Now, let's look at medical physics and nuclear medicine. These are the different kinds of equipment I'm working with day in, day out. We have gamma camera scanners, positron emission tomography scanners. Both of them are coupled together with computed tomography. We get the function from the gamma camera and the PET, and we get the anatomy from the CT scan. We also have calibrators like the one in the bottom corner. Those are used to measure radioactivity before we administer that to our patients. We have interventional probes that are used in theaters to localize tumors or lymph nodes. We have systems, robotic systems for automatically dispensing radioactivity, and then a range of different radiation monitors to measure radioactivity and radiation doses from our patients and from our environment. I've been talking about radiation quite a bit, and what I should state here is our work involves working with radioactivity, but our exposure to radiation remains very low. Each and every one of us gets less than a millisievert of radiation per year due to our work, and this is lower than the public dose limit. Now, we have to test this equipment regularly. We perform a different range of quality control procedures, looking at uniformity and linearity of our scanners or the accuracy of radioactivity measurements. And we use fillable phantoms that simulate the human anatomy to try and evaluate the performance of our equipment. We also develop and deliver a range of diagnostic tests. We measure function at different parts of the body. We look at the thyroid or the parathyroid nodes. We measure the ventilation and perfusion of our lungs, look at targeted receptors for tumors, such as neuroendocrine tumors. We scan our bones to look for metastasis or arthritis, and we also do a lot of brain imaging. I said quite a lot of times, even though we do imaging, I talked about measuring, because our images, as Angela said earlier, are also used for quantification and extracting numbers to help our doctors interpret the image information. And for that reason, we actually do quite a lot of computing, image computing and image processing. There's a couple of examples here. The top one is called a DAT scan, and it's a scan of the brain of a patient with tremor. Their consultant wanted to find out if this tremor is due to Parkinson's. We gave them a specific tracer that binds to the striata, and we quantified the amount of this tracer and plotted it. The left and right striatum are the little red dots here. We plotted it against the corresponding uptake of healthy individuals that come from a European database that our team has contributed to. This patient's uptake is within the blue lines. It's in the normal range. So this patient does not have Parkinson's disease. That's one example of quantification. Other examples include perfusion of the brain. We are looking for dementia and trying to identify if a reduction in signal that we see on our images is statistically significant to help us diagnose, in this case, a patient who suffers from Alzheimer's disease. Beyond the imaging, we also deliver radionuclide therapies. We follow a theranostic pathway, which means that we use the same pharmaceutical labeled with a gamma emitter for diagnostic purposes to localize the disease through imaging. If we identify that this diagnostic agent is targeting the tumors well, we then swap out the gamma emitter for an alpha emitter or a beta emitter, which is a therapeutic agent using the same pharmaceutical. And this way, we can be pretty confident that our therapy will be very well targeted to the same tumor. We can then use the diagnostic agent again to follow up and measure the performance of the therapy and the effect of the therapy on our patient and decide if further therapy is needed. With those therapies, we target disease like thyroid cancer, bone metastases, or neuroendocrine tumors. We also contribute a lot to clinical trials. In 2019, we had over 30 new trials opening. A couple of examples here include a therapeutic trial that has just published its first results and will hopefully come into clinical practice in the next year or so. And this is for treating prostate cancer and metastatic tumor. And you can see an example of improvement over time. And we also did a targeted antibody trial for lung disease. Now, more recently, I started a new project for research in brain imaging, and this is specifically for designing an artificial intelligence algorithm that will help improve our diagnosis of dementia and specifically help us evaluate dementia earlier on. And for that, I am supported by Health Education England through a TOPL fellowship. So just to summarize, what do we do in nuclear medicine? We do imaging and also computing. Any programming experience you have gained during your degree will come handy in a nuclear medicine role. We do therapies, and along with them, the radiation safety and protection that comes with the job. We do quality assurance for our equipment, and we do increasingly more and more research and development to bring new equipment and new methods into clinical practice and to our patients. So that's all from me. Thank you very much, and I'll hand over.
Thank you, Sophia. Okay, so me again, Kat from Radiation Protection. So as everyone else has talked a bit about how they got into their career in a medical physicist, I will just really quickly go over my really complicated and convoluted route, because I actually didn't start off with an undergraduate degree in physics. I started off with a BSc in anthropology from UCL. So I'm a clinical scientist in the radiation protection group, and in my team there are 7 people, most of whom are qualified clinical scientists. I actually work part-time. I work 4 days on and Wednesdays off. And I came into medical physics in a slightly roundabout way. I've been in medical physics for about 12 years. I started off working for the NHS as a technician, as a trainee clinical technologist. And then I got a master's in medical imaging at the University of Surrey, part-time. So I studied part-time and I worked as a technologist. And then I was employed at Plymouth as a trainee clinical scientist, and I actually became a clinical scientist, a registered clinical scientist, by taking route 2, which is the alternative to the STP route. And there's more information on the Institute of Physics and Engineering and Medicine website. But I basically spent a good 6 years or so working and completing a portfolio to get on to become a clinical scientist. And I'm now a clinical scientist at Southampton, having done some work at Portsmouth as well. And I'm working to be a medical physics expert. So about my job, well, the radiation protection group, we're also called radiation safety, diagnostic radiology, we're called a few things, but essentially there's 2 parts. Well, there's 4 parts, but there's 2 main parts. The first is the quality assurance of X-ray equipment. So this is the diagnostic radiology part. So we work very closely with radiographers. We don't ever work with patients directly. The radiographers obviously take the imaging of patients to make diagnoses, but we work closely with them to check that their equipment is safe and optimized. We're also involved in the procurement, commissioning and acceptance of new equipment. And we test the equipment using various test objects. This is one that we use. So when I'm talking about diagnostic X-ray equipment, I'm talking about a huge variety, and it ranges from little dental X-ray equipment that just take pictures of a single tooth, all the way up to CT scanners, and with things like the fluoroscopy units used in cardiac cath labs in between. And I mentioned about optimization. So this is a picture of some optimization work done on a CT scanner, and we use things called phantoms. This is a pediatric phantom to make sure that the equipment that we're using is giving as low a possible radiation dose for the best possible image quality. That's the whole principle of our work. So we work a lot with equipment that gives off ionizing radiation, and for that, and because of that, one of the main focuses of our job is just to keep the radiation dose to our patients as low as practically possible. So that brings me on nicely to the radiation protection side. You could say that keeping our equipment safe is radiation protection, but then also we need to keep, so that helps to keep our patients as safe as possible, but we also have a responsibility to keep our staff safe. So we do things like the occupational monitoring. So we issue TLD badges to, sorry, I'm not sure they are TLD badges, but they're little dose badges that all our staff that work with ionizing radiation wear, and we watch and we monitor those results. We might get involved in PPE and making sure that everyone's wearing adequate PPE and that it's sufficient. So I wrote a paper about the efficacy of lead glasses to be used by members of staff when they're using ionizing radiation. We might check that our facilities are safe as well, so that the environment and members of the public are also safe. So this is my colleague Fiona testing that there's no radiation leakage coming out the ceiling of a CT scanner. And then also we do quite a lot of training. So we do a lot of training and teaching for other members of the trust. So this is actually a training session that medical physics helped out with. It was a whole training day about chemical, biological, radiological and nuclear protection. And these are people wearing hazmat suits. Then, so a slightly maybe smaller section of what the group does, but very important nonetheless, is that we look after people members of staff and patients that are undergoing non-ionizing radiation procedures. So that might be using ultraviolet for treatment in dermatology departments, but it also might be using lasers. So we do a lot of laser safety work. We also teach about laser safety. So we would teach surgeons and such like who are using lasers on patients, the best ways in which to keep themselves and their patients safe from the lasers. By the way, pretty much all lasers that are used in hospitals are class 4, so do carry the highest risk, or in the highest risk category. So it's really important laser safety work. And then finally, we also do a bit with radioactive waste. So there's lots of legislation and guidance about safe disposal of radioactive waste. We have to keep the environment safe. And waste is generated by nuclear medicine and interventional radiology and oncology as well, because patients are administered, as Sophia was explaining, you can administer patients with nuclear medicine both for diagnosis and for therapy. And so this is a picture of us rehearsing the transport of radioactive sources and making sure that the whole route for anything radioactive in the hospital is really strictly monitored, just to make sure that everything is as safe as can be and that we meet all the regulation requirements as well. We had an interesting case, actually it was a case in my last trust where we had a patient that had been administered with, or was about to be administered with, radioactive substance for therapy. And then they were about to go home to their houseboats. And we had some issues looking at the discharge of their radioactive waste. So they produced radioactive waste as sewage, but then it was stored on their houseboats. And that meant some interesting radiation protection issues came up. So that's a bit of a whistle-stop tour of radiation protection. I think that the main point that I want to get across is that we, in this group, we do deal with a huge variety of work. We and completely different things. So the people that we tend to employ are the people that when they pick up the phone, it could be anything from a laser safety question to a radioactive waste question, and someone that enjoys that sort of variety in their job. And now I will just pass you over to Jen to talk about radiophysics.
Hello, everybody. So thank you very much, Kat, and everyone else. I'm going to talk to you about the radiotherapy physics group, part of our medical physics department. So I am also a principal clinical scientist within radiotherapy physics at Southampton General Hospital, and I also have education and training lead role. So my current working pattern, well, let's say before COVID, I was working 26 hours over 4 days, and I'd increased my hours at that point to take on the education and training role, and all those hours were 100% on site. Then COVID hit, and rapidly lots of people within our department were asked to work from home, log in remotely and do a portion of their work from home, and that varied according to different people's circumstances. And I did 1 day work from home. I have recently changed to working my hours over 3 days, as I was finding it hard to leave at the end of the day and working too many hours. Originally, I worked full-time until my first maternity leave, and one of the benefits of the NHS is I was able to take a year's maternity leave for each of my 2 kids. And I've also had a 3-year career break when our family lived in the USA. And I would say that particularly during COVID, there has been a great deal of flexibility in working patterns, both from the side of the department accommodating employees' needs, and also flexibility by employees accommodating the needs of the service that we want to provide without having any interruptions. I did my physics degree at the University of Warwick. I did an MPhys in physics, and that was a 4-year undergraduate master's degree. I did a quick Google to get my pictures here, and I hadn't realised that there was a lot of controversy when the University of Warwick changed from its traditional logo to its newer logo. That was new to me. I was 27 when I got my first non-training job as a medical physicist, and like many others I find in medical physics, there's not many that take a very direct route. I did my 4-year degree. I did a master's in radiological health physics in California, and it was then at that point when I came back to the UK, I decided I wanted to enroll in the grade A, what was then the NHS grade A training scheme. And as part of that, I did an MSc in medical physics at the University of Surrey. And at that time, the training scheme, I trained in 3 areas of nuclear medicine, radiotherapy, and radiation protection. So what is radiotherapy? It's one of the 3 main cancer treatments alongside surgery and chemotherapy. And many patients often will have more than one of these to treat their cancer. We deliver a dose of ionizing radiation to a tumor site, and this therapy is generally only used for cancer treatments because due to the risk of radiation, we have to make sure that the benefit to the patient outweighs the risk of delivering this dose. So there are lots of different ways that we can deliver radiotherapy, and I'm going to cover the ones that we have here at Southampton, which is most of the main options. We have linear accelerators, often called LINACs, and these are the very expensive pieces of equipment that Rachel was talking about the procurement of. We have 5 on site here at Southampton General Hospital, and we have 1 at our satellite site in Basingstoke, and they can deliver a dose of radiation using either electrons, high energy electrons between 6 and 15 MeV, or photons. We have currently the choice of 6 or 10 MeV. So this is our gantry of our linear accelerator. The radiation is coming in this direction here, down towards the patient who will be lying on this couch, usually on their back, but it can be on their front or on their side. And we have the radiation coming in this direction and an imaging panel underneath. And then we also have, going perpendicular to this, we have an X-ray tube and another imaging panel so that patients can be imaged prior to their treatment and their position checked. And just to point out that this partition wall here behind there is all the workings of the LINAC. You've got all the electronics and very large amounts of mechanical equipment to make this all work. We have 1 superficial kilovoltage therapy unit, which delivers dose with 50 to 300 kilovolt X-rays. We also have a brachytherapy service. Brachytherapy uses sealed radioactive sources, and these can either be through a low dose rate route, where the small seeds, as you can see pictured down here, are permanently implanted in the patient and left there forever. And this, for example, is used in prostate treatments. And we also have high dose rate brachytherapy, and this, a small iridium-192 source, is used in a machine that looks something like this. And this is a reusable source, and this goes in and out of catheters within an applicator that's been placed inside the patient. And this is commonly used for prostate and gynae treatments. Less commonly used, but we have the option of intraoperative radiotherapy. So this is delivering a dose to a patient during their surgery. We have a Mobitron system here at Southampton, and that uses electrons, and that's the picture in the bottom left. And that's our up in one of our theatres here. And we also have the intrabeam system that we provide the service for at Winchester Hospital. And this delivers dose using 50 kV X-rays. And this is for breast cancer during surgery after the tumour's been removed. So we've got the control console trolley here. There's a stand which has many degrees of freedom so that the surgeon can position it exactly where they want. This little silver box here is the X-ray source. And this is the applicator, and it's just that small sphere at the end, which is placed inside the tumour cavity inside the patient. They're irradiated, then we remove all this equipment out of the way, and then the surgeon finishes their operation and the patients have their treatment. Radiotherapy can be delivered by radionuclides, and that's what Sophia has already covered in the nuclear medicine department. And so those are the selection of the most common ways of delivering radiotherapy to a patient. I'm just going to cover now, what do clinical scientists in radiotherapy physics do? So most of our staff do a variety of these roles, but they're sort of divided into slightly different areas. We have treatment planning, where we use software to design a treatment to deliver a dose with a LINAC to the tumour, and we want to give the dose that's been prescribed, but also minimise the dose to organs at risk. So the picture I've shown you here is one of the more simple treatments. This is a cross-section through a patient showing their lungs and breasts. And so this is, we've got radiation coming in this direction, we've got another beam coming in this direction. And by modifying the parameters that we can get a homogeneous dose in the area of the breast that is wanted to be treated. And we want to minimize the dose to the lung and also the heart. Often the doctors can't get what they want, and so we have to offer them what compromises we can offer and what they will need to reconsider for their prescription if it's due to the setup of the patient and the physical layout of their bodies, why we can't do what we try to do the impossible, but we can't always achieve that. We also do quality assurance, as many of my colleagues have already mentioned. A lot of it is checking that equipment is working as it should be, because with radiation and other modalities, the outcome, if your equipment's not working properly, can be very serious. So the QA checks within radiotherapy, a lot of them are making sure that our linear accelerators are working within specifications and making sure their performance continues to match the beam model that has been used in the treatment planning software. And as long as these match, that will make sure that the treatment that we plan in the software will match the treatment delivered by the LINAC. This team also will decide on testing that will be needed following breakdowns and repairs, and they will also commission new equipment and will measure the data that's needed for beam models to be created that are used by the treatment planning software. So in brachytherapy, this is another team that they take care of all the brachytherapy needs in the department. Their primary role is the safe use of radioactive sources above and beyond anything else. But this team will attend theatre where applicators are placed in patients and will advise on the placement of those and the implications for the subsequent treatment. They will plan and check treatments for individual patients and will be on call during treatment in case of any equipment or radiation safety issues. And that also will include routine QA of the brachytherapy equipment. We have a scientific computing group that cover our networking. They will perform commissioning of new software, oversee upgrades and any troubleshooting for problems that people will have. They create in-house software, but also provide a local online help desk that we can log our problems and they can address them, and also keep a record of problems that have been addressed previously and how they
how those were solved and help improve things for the future. And this sounds very similar to what other people have said. What everyone does, regardless of their role, is that we need to make sure that we use radiation safely and according to the regulations that apply. And those are there to ensure the safety of patients, staff, the general public, and the environment. We develop and implement improvements to clinical services, and always working closely with other staff groups, radiographers, oncologists, radiologists, engineers, and manufacturers. So, as others have mentioned, good communication skills are key. That's all. I have seen lots of questions coming up, and we've got one more presentation, and then we're planning to address the questions and answers in one of the slots after that. So Heidi is up next. Thank you very much.
Hello. So I didn't have a chance to practice sharing my screen, so hopefully it will be okay.
It's looking good.
Brilliant. Okay, yeah, so we're running over a little bit, but I think that will be okay. I'm going to talk to you a little bit about the Scientist Training Programme, or the STP, and that is probably the easiest and quickest way to become a clinical scientist straight out of university. It's the training route that I took. So a little bit about me first. I did an undergraduate physics degree at Oxford. I did an MPhys, and then straight away I went into the Scientist Training Programme. I didn't train at Southampton. I actually trained down the road at Portsmouth, and I trained in medical physics, of course, and my specialism was radiation safety. And then in May 2018, I moved to Southampton, so just before I'd completed my training. And then all of that training was wrapped up in September 2018, where I started my permanent role as a registered clinical scientist, and I was 25 then. So I work in the radiation protection team with Kat, and I do all the things that she does. So mostly support for diagnostic radiology and all aspects of radiation protection, ionizing, and some non-ionizing too. Yeah, so that's me. I work full-time. I've never had a career break. I work Monday to Friday, 9 to 5, and I don't really work evenings or weekends, which I quite like. Okay. So as was mentioned earlier, there are a few different routes to registration. I'm going to talk to you about the Scientist Training Programme, so the STP, and that's a 3-year work-based formal training programme, and it's run by the National School of Healthcare Science. It's the training programme for all clinical scientists, not just medical physicists, but we do make up a really big bulk of them. There is also another route, the IPEM route 2, which Kat and a couple of people have mentioned. So that's an alternative route where you have to build up a portfolio. Generally, it takes a bit longer, but that really depends on the experience that you have coming into it. Yes, I don't have any experience of that, and I can't answer any questions, but potentially someone else could if you have some. So a bit about the training programme. There are 2 main aspects of the training. Firstly, there's the academic learning. So that's a full-time, fully funded part-time master's degree. Where you do your master's, I think, depends on which trust you are doing your training at. So for our trainees in Southampton, and it was the same for me in Portsmouth, I did my master's at King's College London. So part-time over those sort of over the 3-year training, you'll be away every now for different periods of time. I did one big chunk for 3 months, and I also then went back for a few weeks at different points to do lectures and exams and, you know, university things. And then the other aspect of the training is the sort of work-based learning and the training that you're doing in the department that you're working in. So that would be a program of training within your trust, and you will submit evidence of competence using an e-portfolio, and you'll build up lots of evidence and get things signed off while you're doing that. And then to complete the STP, you need to have done 3 things. You need to have done the MSc and done all the work associated with that, so coursework, exams, and of course you have to do an MSc project. You need to have submitted a complete e-portfolio covering all of the different competencies, and then there's a OSFA assessment at the end, which is an in-person assessment where you'll be asked to do lots of different tasks, and you need to demonstrate that you are capable. And if you do all of those 3 things, then you can register as a clinical scientist, which is great. You will be employed by your trust if you're on the STP program. So whichever hospital or trust that you're working for, they will be your employer. And the training post is band 6, NHS Agenda for Change, which I think is currently around 31,000, but I'm not sure 100%, but not too shabby. So if you join the STP or as part of medical physicist, the first thing you'll do is rotations around the different specialisms. So you'll spend a year going between all the different specialisms, and then after that you'll choose a specialism and you'll spend the next 2 years in that specialism, getting good at it. So previously, the specialisms were radiotherapy physics, imaging with ionizing radiation, radiation safety, and imaging with non-ionizing radiation. But that is changing, and I don't know the exact names, but there's still radiotherapy physics. Then there will be a nuclear medicine rotation, I think, and then radiation safety and diagnostic radiology. And then I'm not actually sure exactly what's happening with the non-ionizing radiation, but that mostly covers MR and ultrasound, I think. So I'm not that sure about that one, but that's changing hopefully for 2022, but I'm not, it might be delayed because of COVID again. So keep an eye out. You also have to demonstrate different professional practice things, which are the same for all the different types of trainee, not just medical physics. And you'll also have you'll have to do an elective, which is a sort of 4 to 6 week placement where you can go and do something different. I went to Nuvia in Oxfordshire, and it was commercial radiation protection, so it was related, but it was completely different. I left the hospital for a month and got to go and decommission nuclear sites and things, which was really interesting. Other people have stayed in the hospital. Some people go abroad, but there's that chunk of time as well that you can do something with. So to talk a little bit about the application process, you apply directly to the national school. You don't apply to the trusts, and then there'll be, you'll rate all the possible trusts in the order of your preference, and they'll allocate them that way. So I think the applications usually open around February time, and the shortlisting is probably around now, March and April time. And hopefully you will be shortlisted, and then you'll be invited to interview, and it's a sort of national interview program. I had to go to Birmingham, but that was quite a few years ago now. And I had to go to 4 different stations. There was a specific medical physics interview station, there was a scientific thinking interview station, and there was a leadership one, and then there was like an NHS values one as well. And I think all the candidates got scored on how well they did. And hopefully you do well and you get offered a position in one of the trusts. And that's sort of the application process. If you want some more information about the STP, then you can go to the National Schools website. Lots of information on that. IPEM is the Institute of Physics and Engineering and Medicine, which a lot of people have talked about already. They have a lot of information about training and careers and jobs there. There's also STP open days at a lot of different hospitals. I went to one in Oxford a few years ago now. Information about STP open days can be found on the National Schools website. And also sometimes trusts have their own open days, so not like an STP open day, but the trust will be open. I know that UHS often do one around January time. I'm not sure what's happening with open days because of COVID at the moment, but you can have a look around for them as well. I didn't do any work experience or anything like that. I went to an open day and I did some reading and I did an optional module at uni, because I know that's a question I get asked a lot. Work experience is really great, but it can be difficult to get hold of in hospitals. So I didn't do any, but I did go to an open day. That was actually all I had to say on that. So I think we've got a Q&A session. If you want to pass on to that, was that okay?
That's brilliant. Thank you very much. Okay, we've got loads of questions. It's really great that everyone's been typing stuff in. Because there's so many and we're nearly at past, are we okay to go very slightly over our past? I'm asking that to the Southampton people.
Yeah, of course. Or if you prefer, you can go to Gather Town, where participants can talk to each of you individually. So up to you.
I think if we go for a quick 5 minutes, I'll try and whiz through as many questions as I can, and then we'll go back to Sophia because she's got her poll to do, and then we'll probably end up finishing about 3:35, if that's okay with everybody.
Yeah, sure, and I'll share the Gather link in the chat.
Okay, so let's have a look at our chat if I can get my questions back up. So I'm going to whiz through some of them just so we can get through as many as possible. If they're easy answers, I'll just answer them, but otherwise I will shout them out to one of my colleagues and get the most appropriate person to ask. Okay, so first one, is it possible to apply for shadowing in one of the medical physics departments of the NHS? I would say historically people have done work experience, but right now due to COVID, I don't think anyone's allowed to take in any non-essential people into the department. So I would try inquiring about that to wherever you're interested in a few months' time. But right now, us at Southampton, we're not bringing anyone in at the moment. A question, can we become medical physics with a one-year master in medical physics, or do we have to join the STP? So as has been addressed before, you don't have to do the STP. It's the most direct way, but there are other routes in. If biologists also apply for the same STP program, does this mean it's more competitive for physicists to get a place? So the scientist training program covers lots of different specialities, but hospitals offer training places in specific specialities. So our hospital offers training to pharmacists, there's bioinformatics, and I think genetic counselling. So we're not, if you want to do medical physics, you're competing against other people who want to do medical physics for all the medical physics places. You're not directly in competition with people who want to do other specialisms. When do applications for the STP program open? So we had some online open days in January. I think they open and possibly close in February. The best place to look at that information is the National School of Healthcare Science website, and they usually have like a page with a timeline on it for STP applications. One of the questions was, what do you do in radiation protection in medical physics? I think Kat did an excellent job of answering that one already. Angela, you've got a fan. Would you be willing to share your thesis? I'm hoping to go into neurophysics and would love to read it.
I saw that. I'm not sure. Anyone would want to read my thesis. It was a long time ago.
I think our contact details are on the website, and do get in touch privately, and I think through the hospital website we're round and about on there. Oh, Angela, what are MR Linacs?
Well, I don't know if that's a radiotherapy or an MRI question. They're a Linac with an MRI scanner embedded, I suppose, to enable what do you call it, on treatment imaging, Jen and Rachel? So imaging whilst treatment is taking place, or kind of around when the treatment is going to take place, but using an MRI scanner as opposed to X-ray imaging. And I'm using vague terms because I'm not quite sure what type of X-ray imaging you normally do. But the advantage is that you get much better soft tissue delineation with MRI. And quite often the structures you want to avoid in radiotherapy are soft tissue structures. And it just gives you a better idea of what you're hitting and what you're not hitting with the radiotherapy.
And I think you can probably visualize your tumor better, because quite often they're not particularly easy to see on CT images, which is what we do get. And there are, do we know how many are in clinical use? 2 or 3?
1 or 2, not many yet. I think
about 20, isn't there, in the whole consortium, but in the UK, about two or 3, I think.
Yeah, still.
So they're a new thing, and lots of things you hear about those going on. A question for, I think it must have been Sophia. You talked about comparing your nuclear medicine results to a European database of normals. The question is, since you use the European database, isn't this an issue for early detection in non-white communities, as there is a white majority population in Europe, although very large populations of other communities?
Yes, that's a very good question. And actually, most of the participants in the European database are indeed white. However, there are a couple of other databases available, one designed in Japan and another one in the USA. And the USA one is more representative of different communities. And the uptake of this specific tracer in the brain seems to be the same, independent of ethnicity. So we don't expect any bias because of using a European database. The choice of the European database depends on the kind of imaging parameters we use, and we have optimized our scanners to quantify the uptake on the tracer. That is, ethnicity is a problem for other normal databases, so it is something we do need to consider when we are designing those things.
Thank you, Sophia. Question for Angela. Do you work with Alzheimer's and dementia?
A little bit, starting to do more MR. Sophia really is Alzheimer's and dementia expert, to be honest, amongst all of us, and that's what her fellowship's in. But we use a variety of imaging modalities to look at diagnosis of dementia. And Sophia has talked about her project where they're using SPECT imaging, and you've done a lot of work here, haven't you, Sophia, in using SPECT nuclear medicine imaging to very accurately diagnose dementia. MR's at a slightly different stage, and we use it to look at how the brain has shrunk, but that's a really crude measure of what's happening in dementia. So there are other techniques that are more research techniques that we're developing and evaluating, I suppose, in MRI. Sorry,
Thank
Sophia,
you.
do you want to go?
Another question is, what nanoparticles are used at UHS? Does anyone want to stick their hand up and tell me anything about that?
I wonder if that was linking to any of the pharmaceuticals or the microspheres that were in one of my slides. We do use some of our pharmaceuticals are in the nanoscale, some of them are in the microscale, in order to look at things like trapping in the smallest capillaries. But we do not have functionalization of our nanoparticles in the way you would have for medicinal treatments. We use them as carriers for our radioactivity.
Thank you. I've got another question. If we choose the STP program, but then want to switch to research or work in industry or academia, is it possible? Well, once you've done the STP program, you're not tied to the NHS. You can leave at any point. You're free to do so. We quite often get, well, I know of people that come the other direction, come into the NHS from research or academia, and I presume people must go in the other way as well. The only thing I would say is, like, I think if you really thought you wanted to do STP and then realized you didn't, that's one thing, but I wouldn't deliberately choose to do the program knowing that you didn't plan to work in the NHS, because there's these places are limited and highly sought after, and I think departments would be quite disappointed to have invested their time in you for 3 years only to realize sort of later on, when they're ready to employ you as a fully functioning employee, that you then intended to leave. But you know, people do realize, and their careers develop, and they do want to go in different directions later. So yes, you are allowed to choose what you do at each stage of your career.
And Sophia can add to this as well, but I'd say going into academia is not an either or for a clinical scientist in the NHS. We all dabble in research, and some of us do more than others. And there are training routes and, you know, career development routes that Sophia is on to do exactly that, to do academic work within the NHS as a clinical scientist. Sophia, do you want to add?
And I would actually, thank you, Angela. I have to say there is very good opportunities both for doing a PhD as part of a clinical role. There is now the higher specialist training scheme, which you can do after your STP, and it includes research of PhD type. And also after that, there is a lectureship pathway for clinicians who wish to become academics at the same time. So there is good opportunities, and it doesn't have to be one or another. Sorry, Angela, I'm repeating you.
No, it's fine. You clarified. Well done.
Okay, I think we're going to go back to Sophia now to do the VVox repeat poll. Sorry if your question didn't get asked. Hopefully we've covered most of them in the training. One question I do just want to answer is, how does the grade A training work? How is it different from STP? Grade A training no longer exists. It's what it used to be called. It's bitten the dust, and it's been replaced by various things, and the current training scheme is STP. So don't worry about the grade A. It's just that when we were training, that's what the route was. So thank you everybody for showing up here. So over to you, Sophia.
Hi, can you hear me?
Yeah.
Yes, all good. Yeah. Thank you, Sophia. I can see your screen too.
Lovely. So let's see where we are. We do have quite a lot of questions left, and we will join Gather Town immediately after this session, so we can discuss those directly, and you can ask whoever you wish. I'm going to close this poll and move on to the next question. We've already answered this one. Going back through the same questions, and there was one about gender and medical physics. Lovely, I can see the answers pulling in. Brilliant. So you were listening to Kat carefully, and there is indeed the 50-50 share of male and female medical physicists. And do you know how to become a medical physicist? Following the talks by Rachel in the introduction and also Heidi at the end specific to the SDP. Oh, that's wonderful to hear that most of you know how to do it, and we're happy to talk more about it in Gather Time in a minute. And then, can you have a research career in medical physics? Brilliant. And I think I have accidentally skipped one question. Oh, well. Do you know a medical physicist? That's wonderful. I would suggest we wrap it up here and see everyone in Gather Town so that we can continue discussing there.
Okay, so I think if we want to do the Gather Town, the link is in the chat. So that's for us presenters who are not. Oh, it's telling me there's no room of this ID.
Thank you so much.
Thank you.
Thank you for attending, everybody. I hope that answered some of your questions and you found it interesting.
I'm still having trouble entering Gather Town. Does anyone know?
Yes, me too. I'm not getting in there.
Yeah, it's not working.
Do you have
see
to
what
be
I can do.
registered or something?
Yeah, I'll see what I can do.
Okay. Do we want to take a few more questions here while we're waiting, as we cannot go into Gather Town? Oh, try that link. Oh, this link is working.
Okay.
Good.
So what is Gather Town? How is it different? Is it one big room?
It's, you can set it up, and we've made our own room. So you create your avatar and then you can move using the arrows. You can interact with different things in the space, and then you can turn on your camera and your mic, and when you get close enough to somebody, you can talk to each other. It's
Okay.
really cool. By the way, is Kat still here?
Hello, I'm here.
Hey Kat, in your third slide, when there is the gender and medical physics,
Yes.
the percentages don't add up.
Oh,
It
really?
was 33 and 31.
Oh, so it was those were the numbers, 33 and 31, and then I think you had percentages underneath.
Yes, you did.
I think, which were
47 and 53, wasn't it? I think.
I mean, you said the correct numbers, just on the slide itself, it said 33 and 31.
And then next to those numbers, it said the percentage. It like said the numbers 33 and 31, and then there was a comma,
Yeah.
and then it said the
and
percentage.
then comma percentage.
Yeah.
Oh,
If that's not
okay.
clear, I'll just remove the data labels and I'll just put the percentage in.
No, it's okay.
I'll do that for the
guess
next talk. Yeah.
To me, it looked like 33.50 something percent. And I was like, those two don't
Yeah, it
add
doesn't
up.
add up.
And like the
you.
percentages that you said were right, and I was like, how?
Yeah, no,
how?
I've just made it clearer on my slides then. Thank you.
No worries.
Okay, so I think, yeah, everything was okay. I went over my allocated time, but I think it worked out by catching
I
up
think
at
I
the
went
end.
over quite a lot as well. I'm sorry, and I had said it was going to be shorter.
Is there anything that we need to change for the second session? I mean, I'm pretty happy with everything.
I think it would be nicer if there's more time for questions.
Okay, so if we try and clip ourselves short a bit, whiz through, and then we'll have a bit more time at the end.
Maybe for
I think there's also a second session for medical physics. Will be on Gathertown or here. I think here, isn't it? I think here.